Welcome to tonight's webinar with Dr. Marie Tchetgen on how to regain control of your bladder. This evening, Dr. Tchetgen will be speaking about bladder dysfunction, the common symptoms patients experience, and treatment options available that may help you regain bladder control. My name is Tiffany Bain. I am the Field Marketing Specialist with Axonics. I will be facilitating the webinar tonight. Without further ado, I would like to introduce Dr. Tchetgen.
Welcome to this presentation this evening. It's a first for me to do a webinar, so it's very strange to talk and not see who's in the audience, but all the same, hopefully by the end of the hour, I will be used to this process. Tonight, we're going to discuss bladder and bowel control issues and go through a brief overview of some of the exciting options that are available for the management of some of these conditions. As mentioned earlier, I'm Dr. Tchetgen. I'm dual board certified in urology and female pelvic medicine and reconstructive surgery. It is basically a field that addresses some of the issues of bladder control, those that go a little bit beyond initial traditional treatments, but evolve into some of the more complex treatments that we now have available. I also do a lot of diagnostic testing for various bladder conditions, and I can go into this a little bit with more depth at the end of the presentation if there's any need for any clarification. Tonight's presentation is being sponsored by Axonics, sacral neuromodulation therapy for urinary control. And this is a brief overview of some safety information that you should be familiar with. Basically, this presentation is not intended to be diagnostic in nature. It's really informational. And if you have any specific questions about your current situation, it is best to discuss it with your private physician. All right, well, let's talk about bladder and bowel issues. This is obviously a topic that is not of common conversation fodder. This is not exactly cocktail conversation, as one might say, but some patients or some of you in the audience that deal with these issues are familiar with some of these scenarios. People with bladder and bowel issues will have a few adaptive behaviors to try to cope with some of their symptoms. As this gentleman says here, you drink less before you go on a trip. You may miss the best part of a show because you absolutely cannot hold it or embarrassed about having a potential accident in the auditorium. And another behavior is what we call bathroom mapping. You always know where all the bathrooms are if you go to the mall, because you never know when you might need to get there quickly. So these are some of the symptoms that may inform you that you do in fact have an issue. Most patients don't need to be told. They typically know that these issues affect their quality of life and can really have a pretty devastating emotional effect, primarily because it comes with a lot of embarrassment and shame. But I'm here to tell you that you're not alone, and patients suffering from severe symptoms or even severe symptoms of overactive bladder can get help. We have a lot more treatment modalities than most of you may be aware of. And the goal of tonight's presentation is to discuss some of these with you. Jill is a real Axonics patient who suffered from an overactive bladder, but she's one of 50 million people in the US that have issues with an overactive bladder. Half of those patients will have symptoms so severe that it restricts their ability to participate in a lot of their social engagements and create really a very negative impact on their quality of life. Similarly, about 20 million people suffer from fecal incontinence. I'm not a colorectal specialist, but there's a lot of overlap in the control of bladder and the control of bowel. And so some of these therapies, in fact, can be beneficial in both of these conditions. So let's talk a little bit more about these conditions. So If you have an overactive bladder, it is defined primarily by a sudden urges to urinate and an inability to control these urges. This results in a loss of bladder control, with the severity of leakage varying from just a few drops to complete bladder emptying. As you can imagine, this can be very devastating. This bladder dysfunction conditions also include issues with bladder emptying, so urinary retention. And this basically describes an inability to completely empty one's bladder easily and without drama, as I like to say. Fecal incontinence is pretty self-explanatory. It's an inability to control the bowels with an involuntary loss of stool. Before we talk about pathology, we should review how a normal bladder should work. So the bladder has two basic functions. It needs to fill and store urine, and then it needs to empty when the bladder is full. And there's a complex mechanism that coordinates all this activity, and it includes muscles and nerves. And when we talk about nerves, we're talking about motor nerves, so nerves that actually direct function, and then sensory nerves, nerves that actually mediate sensation. And so as your bladder fills, when it gets to a certain volume, you should get a sense of fullness and a initially slight urge to urinate. The rate of filling of the bladder is going to depend on your fluid intake. Once that urge to urinate becomes more pronounced, there's some signals that go to the brain and lets you know that it's time to urinate. When it's time to urinate and you make your way to the bathroom and you start the process of urination, there's a process of relaxation of the pelvic floor muscles, which in turn signal to the bladder that it's time to urinate. And all of this happens in a very coordinated manner, not thought out at all, and certainly not controlled. When we think about a process of toilet training, for example, when babies are born, their bladders work more or less automatically. The bladder fills and empties in a diaper, for example. As babies or toddlers get toilet trained, they gain that brain control over the bladder. And that's part of that mechanism of the nerve development between the brain and the bladder that essentially constitutes bladder control. An overactive bladder is one where this whole mechanism doesn't work as well. And so the bladder becomes overactive because there are frequent and urgent needs to empty the bladder, not related necessarily to how full the bladder is. This can result in an unintentional loss of urine. It also comes with other symptoms such as urinary frequency. And usually we define that as having to go to the bathroom more than 8 times a day, but you can understand how that can also be correlated to what the fluid intake is. Urinary urgency is defined by the sudden urge to urinate that is difficult to defer and may in fact lead to loss of control as well. And urgent continence really defines that loss of control. So you can have urinary frequency and urgency, but not have urgent continence, but that can still be as disruptive because the fear of leaking can be enough to drive you constantly to the bathroom, and that can just be as disruptive. Nocturia refers to getting up at night. So we define that as getting up more than 2 times a night to urinate. So what happens with an overactive bladder? So it basically is thought to be due to an abnormal communication between the brain and the bladder. So it's almost as if the bladder has a mind of its own. And so you may feel like you need to go to the bathroom, but it's not quite time. You're trying to make it to the bathroom, but it's like your bladder has a different idea about things. And so that urgent feeling takes over. And so you may in fact hurry to try to get to the bathroom. And if you're lucky, you might make it, but most often as you're entering the bathroom, the urge may be overwhelming. The bladder may start to contract. And so that's defined as an unwanted bladder contraction because you have not permitted your bladder to start to go. And rushing or leaking while trying to make it to the bathroom becomes a hallmark of this condition. I would like to take this time to note that the #1 reason for falls in the elderly is really associated with rushing to the bathroom or leaking on the way to the bathroom. So that can lead to hip fractures because of falls in the middle of the night. So suddenly something that may seem like an innocuous bladder control issue can really lead to more complex medical issues as a result of this problem. So there are various types of incontinence, and it's always important to kind of understand the differences between these different types of incontinence because they're actually associated with different treatments. And so not all leakage is the same. So let's talk first about stress urinary incontinence. That's defined as leakage that happens because of coughing, sneezing, anything that puts pressure on the bladder. This leads to leakage from the urethra. This type of leakage is usually a lot more predictable than the overactive bladder or the urgency urinary incontinence. And because it's more predictable, most times patients with stress incontinence tend to live with this condition a little longer than they're willing to live with an overactive bladder because they do have a sense of predictability, and so they can accommodate for this type of leakage. So for example, stress incontinence that's happening with exercise may lead you to wear a pad before exercising, or may lead you to avoid the type of activity that leads to leakage. Urgency urinary incontinence is really characterized by a lack of control. So there's no sense of timing as to when these symptoms will happen. It may happen in the middle of church. It may happen at the grocery store. It may happen while you're asleep. And so you can already see how disruptive this can be and how frustrating it can be for many patients. And then the worst case scenario is where patients have both conditions coexisting. And so you have the predictive aspect of it in addition to the unpredicted aspect of it. And so it just seems like the leakage is constant and that any activity in fact leads to leakage. So a quick review on the rectum, on the bowel function. It's a little similar to the bladder in the sense that the mechanism of filling and emptying of the rectum is also one that's automated. It's mediated through nerves, through receptors that monitor stretch within the wall of the colon. The signals go to the brain. Again, the brain then sends signals down to the pelvic floor and to the muscle of the bowel, and thus coordinating the whole act of defecation or having a bowel movement. And so these mechanisms, again, are automated mechanisms. They're not always controlled. The only decision-making process comes to when you make the decision based on the feedback you're getting from your body that it's time to go to the bathroom. And then you get to the bathroom and in fact, allow yourself then to have a bowel movement. So patients with fecal incontinence don't have that control aspect to it. And again, just like with the bladder, you have this uncontrolled loss of stool that could be solid or liquid or mucus. Similar to urge incontinence, urinary urge incontinence, you can have urge fecal incontinence. You can have passive incontinence where there's a slow seepage of stool associated with soilage. The urgency, just as with the bladder, is again the sudden need to have a bowel movement and one that cannot be deferred. And the fecal incontinence comes from the inability to defer this urgency and therefore a loss of control of the bowel. Passive fecal incontinence is one that's happening without awareness. And so most patients with this condition will not be aware that they're in fact losing control of their bowels, and they may just notice it when they notice the soiling on their undergarments. So the main impact of these conditions is that it has a very negative effect on one's quality of life. It'll limit your social activities and social interactions, limits your participation in physical activities. This will then lead to isolation, depression, loss of self-respect in some instances. Of course, there's fear of accidents and the embarrassment that comes from that. Within intimate relationships, patients start to avoid intimate contact because of embarrassment and the fear of offending their partners with their loss of control. Occupationally, it can affect your participation with work, decreased productivity because of the distraction that constantly having to go to the bathroom, or worse, having loss of control can have. And then ways of accommodating for that, including pads, diapers, special bedding, precautions for claws, come with an associated cost, as you can imagine, but also that in fact, patients start to even choose color of clothing just based on a way to mask any potential accidents. And so wearing darker colored clothing or padding or traveling with several changes of clothing in order to accommodate for any potential accidents. So the impact is huge. I often tell my patients, you know, these conditions probably won't kill you, but they will certainly kill your quality of life. So a few points I'd like to make, because obviously lots of patients think this. No, this is not a normal part of getting older. It certainly happens more often as we get older because of some of the changes that happen to our bodies as we get older. But we cannot consider it as a normal part of aging. Lots of patients age without having these conditions. For women that have particularly stress and urge incontinence, it's just not part of being a, you know, just think this part of being a woman. Certainly a lot of women develop these conditions after having had children. And many think of it as kind of a baseline that's, you know, to be dealt with. And certainly if it's mild, most of us can accommodate that. But as these symptoms get more severe, they really start to have a significant impact on quality of life. And if you're otherwise healthy, you can see how that can really start to take a toll. For men with prostate issues, or with these symptoms, the thought usually is to blame the prostate. No, the prostate is not always the reason for the loss of control or for the urgency. A lot of times it's the bladder, and sometimes the bladder issues may in fact occur as a result of a prostate issue, but certainly not exclusively. And last but not least, it's really not your fault. It's not something you did. It's not something you necessarily brought onto yourself. And these are conditions that can be helped if the embarrassment or the reluctance to seek help can be overcome. All right, so the good news is there are treatments to help regain control of your bladder and your bowel. Well, let's talk about these treatment options. So an easy way to look at it is to kind of navigate to what we like to call a patient care pathway. And the first step of that pathway is, in fact, to talk to your physician. If you're talking to your primary care physician, you may ask them to refer you. I mean, primary care physicians are extremely busy. There are many general conditions that they have to deal with. They're usually pressed for time. And so some patients just, and some physicians won't bring up those issues if they have a lot of other issues to discuss with you, like your heart and your lungs and your diabetes and your hypertension. And those are more life-threatening than maybe bladder control issues. And so often those go down the list and maybe, you know, either avoided or just overlooked. And so bringing up the symptoms, just, you know, not necessarily requiring that your primary care doctor treat you at that point, but you may just say, you know, I'm having some issues with my bladder. Could you refer me to somebody or a specialist that can help me with these conditions? And most of them will be more than happy to. So once you see somebody like me, or even just a general urologist, usually a review of symptoms is kind of where the whole process starts. And just through some question and answers, we may try to elucidate what the characteristics of the symptoms are, because as you saw, there are many different types of incontinence, and not all incontinence is the same. And so similarly, because not all incontinence are the same, not all treatments will apply to all patients. So first, we want to discuss your symptoms. We may have you do a little baseline diary of your symptoms. There may be some diagnostic testing that may be necessary to understand those symptoms and better classify them. And then we kind of have a discussion of what the different treatments options are. For a lot of patients, the initial treatments will really be about enhancing your body's ability to control itself, and then also some education about some of the lifestyle changes that may be helpful to enhance the bladder control. And then third, we may discuss prescription medications that may help. Sometimes physical therapy may help enhance the strength of these muscles that naturally are supposed to help control the bladder, whether we're talking about stress incontinence or urge incontinence or even fecal incontinence. So there is definitely hope. I think a lack of information sometimes prevent patients from seeking help. I've had many patients who are just marvel at the number of options that they have and they had no idea about. And, you know, as I said earlier, this is not exactly cocktail conversation. So people are not going to bring this up in any kind of mundane conversation. These issues come with a lot of shame. So just the absence of information sometimes keep patients in the dark. And then for patients that don't respond to some of these initial treatments, then we have advanced therapies. And these will include sacral neuromodulation, percutaneous tibial nerve stimulation, chemodenervation, or Botox injections of the bladder. And we can talk about those in the Q&A sessions in a little bit more depth. So for urinary retention, which is a slightly different problem, again, we always start with just at least talking about the problem. Now, some patients may not even know they have urinary retention. If it happens very subtly, you may not be aware that you, in fact, are not emptying your bladder. Sometimes urinary retention will come with urinary frequency. And if you think about it, if your bladder doesn't empty, it fills up more quickly. So then you end up having to go to the bathroom more frequently. And so urinary retention can sometimes present like overactive bladder because you'll have the urgency, you'll have the frequency, you may even leak a little bit. But the hallmark of urinary retention is that when you checked, you realize then that the bladder isn't emptying. So chronic urinary retention can be very subtle and can be easily missed. Acute urinary retention is something that happens all of a sudden, usually comes with a very, very strong need to go to the bathroom and an inability to go to the bathroom. So patients will often end up in the emergency room because they're trying so hard to urinate, they start developing a lot of pressure and even pain. Most acute urinary retention issues either happen as the end stage result of having had a chronic problem or may happen as a result of either a procedure, a surgery. And so when we're talking about some of these issues in terms of long-term management of urinary retention, we're talking about patients that don't have just transient urinary retention. It ends up being more of a chronic problem. And of course, we're not going to figure that out until we do some kind of evaluation or some kind of assessment. So reviewing the symptoms, the duration of the symptoms, some testing may be necessary, measuring of what we call a bladder residual, what's left in the bladder after you've urinated. That sometimes is going to be more informative than actually understanding how often you go to the bathroom. And then depending on the severity of the problem, then when we talk about some of the treatment options for this. One thing I like to say about the bladder muscle and urinary retention is that I like to characterize it as almost like bladder failure. So when you have heart failure, for example, and the heart muscle isn't contracting very well, for whatever reason, it becomes a very difficult situation because once a heart muscle has failed completely, there's not a whole lot we can do. And those patients often end up with, heart transplants and pumps and things to help augment the muscle function of the heart. So similarly in the bladder, once the bladder muscle fails completely, we really don't have very good treatments for them. So it's always best with urinary retention to jump on that once it becomes evident that the bladder isn't emptying well. Usually when patients are still able to urinate to some degree, because it means that there's some residual function, but the bladder is telling us it's really struggling. It's having a hard time keeping up with the work it's supposed to do. And so understanding what's leading to the urinary retention helps us understand how best to address it. But once we have patients that show up in complete urinary retention with an inability to urinate at all, sometimes we're very limited with what we can do. So some initial treatments may in fact involve behavioral management. I'll give you an example. If you have a patient that's drinking 2 gallons of water a day and the bladder is completely overwhelmed, and let's say they have a job where they can't go to the bathroom as frequently as they like to, but they feel compelled to, for whatever reason, ingest all that fluid. Well, the bladder starts to train itself to hold more and more fluid. That process stretches the bladder muscle, which then weakens it. And so behavioral management in this setting would first be about reducing the fluid intake and maybe about timing the intervals for urination and basically trying to retrain the bladder into holding a more normal volume. Sometimes we may do a diary so we can have a better sense of what the behaviors are that may be leading to this problem, and then trying to correct those behaviors with just some very specific customized instructions based on those diaries. In men, we may have medications to help the prostate. If the prostate is enlarged, it may get in the way of bladder emptying, essentially blocking out the outlet of the bladder so urine can't flow through. And so in this setting, treating the prostate may help the bladder empty better. And then for patients who have what we call refractory problems, or who don't have, who have issues of bladder function leading to retention, so no obstruction from a prostate, for example, no obstruction from a urethral stricture, for example, but more of a bladder function dysfunction, Sacral neuromodulation as an advanced therapy can be helpful. And again, it's all about stimulating the nerves that help control the bladder to normalize bladder emptying. Clean intermittent catheterization is basically the use of catheters to help the bladder empty because the bladder cannot do it itself. And the alternative to that would be to surgically place a catheter into the bladder to allow for constant bladder drainage. So again, these are things we can go into more depth with during the Q&A session. I've alluded to some of these options here on the slide. So behavioral, we talk about bladder training exercises, physical therapy for pelvic floor. These are all different modalities used during that approach. Medications are aimed usually at relaxing the bladder muscle when it comes to treatment of the overactive bladder, because as I mentioned before, the bladder muscle is overactive, it's in spasm. And so using a medication that allows the bladder to relax can optimize bladder control. Lifestyle changes, avoiding things that irritate the bladder. And usually I provide patients with a list of these things. Sometimes it's a little hard because these habits are long-lived and really, are part of your quality of life. If you like to drink a couple of Diet Dr. Peppers a day, me telling you all of a sudden that that's what's causing your bladder is not always well received. Patients who drink a lot of fluid sometimes will not realize that that has a direct impact on the urinary frequency, and that a bladder, when it's full, needs to go, and that in fact, we don't have medications to allow bladders that are not full to not need to go. So we look at these things very critically, and we always start there. So lifestyle changes can really have a huge impact. A full 40% of my patients will really see improvement just with a few lifestyle changes and not really need to do anything beyond that. In terms of medication, these are just anticholinergics and beta-3 adrenergic receptor agonists are basically types of medicines that can help with the bladder in a number of patients. There are about between 7 and 10 drugs that often can be used. But generally speaking, if 3 drugs have been tried without any improvement, the chance of having a medication work in this setting does decrease dramatically. So after a trial of 3 different medications, I'll start the conversation about what may come next. Let's talk a little bit about percutaneous tibial nerve stimulation. It's a way of stimulating or controlling the bladder through the nerves that feed into the control mechanism for the bladder. So in this instance, as you can see in this picture, this is tibial nerve stimulation. The tibial nerve travels from right behind the ankle bone, the inner ankle bone, all the way to the pelvic plexus, and that's the nerve center that helps control the bladder. This is a therapy that's applied through a needle, almost like a little acupuncture needle that's placed next to the nerve and to stimulate it. These sessions are done 30 minutes weekly for 12 weeks. And typically, most patients will start to see a response, which usually translates into less urgency and less frequency and less urgent incontinence after a few sessions. After those 12-week sessions, we reassess, and if there's a need for long-term maintenance, some patients may do well with just one treatment every six weeks. Usually every 4 to 6 weeks, one treatment may be all that's needed to maintain the effectiveness long-term. The downside of such a therapy, as you can imagine, is the tediousness of having to come into the office on a weekly basis. There are some neurotherapies where a stimulator or an electrode can now be implanted to help stimulate the tibial nerve, and that's been FDA approved and is just starting to get marketed. So this approach is about to get a lot more popular, if it's not as inconvenient as having to come into the office on a weekly basis. Chemodenervation, as I mentioned earlier, is really about forcing the bladder muscle to relax and not be so spastic. And so if you have an overactive bladder that's due to spasms within the bladder muscle, as illustrated here, you can get some of those muscle fibers not to spasm as much by injecting small aliquots of Botox within the bladder wall. And that causes this muscle to relax. Of course, you want the bladder to relax enough that you don't have to go frequently or lose control of the bladder, but we certainly want that bladder to still be able to contract in order to urinate. And so that balance is important. And part of the counseling that we do around this treatment is really about that. Some of the diagnostic testing we might do is also to determine whether a patient is a good candidate for this therapy and to be able to counsel them about some of the potential side effects given what their bladder function is. Generally speaking, Botox is it's a toxin that usually wears off. And so the effect of the medication, of the treatment, is not going to be permanent. This is a treatment that is understood to be temporary. On average, this treatment will last 6 to 8 months. And then the symptoms start to recur slowly. Most of my patients that go through this therapy get it about once a year. Now let's talk about sacral neuromodulation. And this is an advanced therapy. And this therapy is indicated for patients that have failed what we generally call first line and second line therapies. So first line therapies usually refer to therapies that include fluid management, pelvic floor therapy, behavioral modification. Second line therapies involve medications. And then third line therapies are typically indicated for patients that either cannot tolerate did not respond to the first or second line therapies, or could not tolerate the medication, and really more recently could not afford the medication, because some of these medications have gotten more and more expensive, particularly those that are not generic yet. So sacral neuromodulation is really about trying to modulate the activity of the sacral nerve, which is the command center for bladder control and also bowel control. The idea is really to try to see if stimulating these nerves may in fact allow better bladder control or better bowel control. And this is usually done in 2 or sometimes 3 phases. The first phases are really about trial therapy to see what kind of improvement patient experiences. And if this trial is successful, then we proceed with a permanent implant for longer lasting results. So Jill and Melissa are real Axonics therapy patients. I have many very happy patients as well, where this therapy is just one of the approaches to sacral neuromodulation. It is indicated for the overactive bladder for urinary retention and fecal incontinence. And it's about trying to control things at the nerve level, as I mentioned earlier, essentially through something we can almost call like a pacemaker. And so this electrical stimulator stimulates those nerves and allow the resolution of some of the pathology in terms of bladder control. It's almost as if it allows you to restore normal bladder control through stimulating the nerves that are involved in bladder control. The idea here is to normalize the communication between your brain and the bladder and the bowel. The treatment itself does not stimulate the bladder either to be controlled or to go. It basically works on the nerves to allow that normal control to be restored. And so I almost like to think of it as when I alluded to the baby bladder in the beginning, you know, you get toilet trained and then you gain that control over your bowel and bladder function. And then something comes to disrupt it. So all of a sudden, whatever you're telling your bladder to do, it's not responding. Your brain signals are going down to the bladder, but something is in the way of getting those signals to the bladder or to the bowel. And one thought about how sacral neuromodulation works, to really simplify it a whole lot, is to say that the sacral neuromodulation removes that barrier that's preventing those brain signals to get into your bladder or your bowel. So all of a sudden, that bladder is better controlled by you. When you decide you're ready to go, you can control the bladder to go. If you are overactive in terms of bladder activity, you can hold it when you need to hold it without having to work at it. Essentially, it restores normal communication between your brain and the bladder and bowel. And this obviously will result in improvement of the symptoms. So the first step towards long-term therapy is first to find out if it's right for you. Usually after patients have gone through the pathway that we talked about and we get to the point where this is a therapy that we're going to consider, we will usually start with a brief testing period to see if the symptoms are in fact improved. Usually patients will have to see at least a 50% improvement in their baseline symptoms to be considered good candidates for this therapy. And I often tell patients wishful thinking doesn't hold the test of time. And so we're really pretty rigorous about trying to determine whether there's enough response to a trial to allow patients to go through with the process of placing these devices, because there's nothing more frustrating than going through the whole process and then determining, in fact, that it really was not as efficacious as one would have expected. Having said that, it is a process that is usually quite successful. Over 75% of patients will have a good response to a trial. And then once the trial is successful for the Axonics in particular, and then you have options as to how to control the stimulation. It can be done through a rechargeable device or through a recharge-free device. And as you can see on this, on the slide, the characteristic of each option are outlined. All I will say is that either option works quite well. Sometimes we'll help guide patients towards one option versus the other, depending on their, individual circumstances. But having these options have really kind of brought a lot of a lot of options to some of us that take care of these conditions, because, for example, one of the limitations, let me go back here. One of the limitations of sacral neuromodulation in the past was really the inability to have an MRI. And that's one option. One benefit of these newer developments is that now patients with sacral neuromodulation devices can in fact have MRIs. A lot of these patients are elderly, and some of them will have back issues or other conditions that require them to have MRIs. And so having that flexibility to be able to access this therapy despite the potential need for MRI is certainly something that's been very welcome. And then once the device is in place, patients can control it through this little remote control that almost looks like a keychain. As you can see there, it's discreet, it's easy to monitor and adjust your therapy through it. And it's really very patient friendly in terms of understanding how it works and being able to control it. There's not a lot of different quadrants to look at and different machines to manipulate. It's really an up or down, on or off type of a system once it's in place. As I mentioned earlier, access to full body MRI is now a reality when it comes to these devices. It was a limitation for a long time. And this is really a very welcome advance. Improvements for patients with refractory symptoms is really pretty impressive. Data looking at efficacy over 2 years shows a 93% satisfaction rate because of clinically significant improvement in baseline symptoms. So it really heralds a new horizon in terms of bladder control as well as bowel control. And over 90% of patients who had been implanted were satisfied with their results, the Axonics therapy, and they would undergo those therapy again if presented with these options. So Jill quoted here, it's fantastic to live a normal life. You can imagine being able to go back out on a walk, not worry about mapping bathrooms and so forth. All right, so that was about the overactive bladder. Let's talk a little bit about stress incontinence. A slightly different problem. This is leakage due to leaking with sneezing, exercise, laughing, coughing, walking, anything that puts pressure on the bladder, pushes urine out, that's stress incontinence. Here's a normal bladder. Bladder stores, bladder empties, as we talked about earlier. During storage, the bladder relaxes. The urethra, which is kind of the closing mechanism of the bladder. During emptying, the bladder contracts. The urethra relaxes and urine flows. Stress incontinence is really a process where all this mechanism is really overwhelmed. And so the internal sphincter muscle or the closing valve is weak. So any pressure on the bladder pushes urine past that. And so any treatment for a condition like this would be aimed at tightening this process. So with this condition as well, you're not alone. There are many treatments that are available. Stress incontinence is a very common condition. It affects 1 in 3 women at some point in their lives, most times after childbirth. Most women will accommodate and deal with the symptoms until they get to be severe. They can affect your quality of life. They can affect your mental health, your physical health, because of associated skin conditions that come from dealing with constant moistness. Obviously, as one gets older, that becomes a bigger issue. It can disrupt social and professional activities. I mean, it's a huge problem. And then you add in the economic impact of having to deal with wearing pads, and you get the picture. So the good news is there are treatments, and we've in fact had very good treatments for a long time for stress urinary incontinence. Pelvic floor exercises is really kind of the baseline of trying to restore a more natural control. Women after having vaginal deliveries, for example, will have a lot of stretching of that pelvic musculature, and that will impact on the sphincter or the closing valve. So physical training of those muscles can improve stress incontinence. But beyond that, we have interventions that can also help tightening those valves. The sling is a treatment that's surgical. It's been around for many, many years. Urethral bulking has also been around a long time, but the materials that were used for bulking have evolved over time and have gotten to make this option a lot more appealing and a lot more successful in terms of treating stress incontinence. And so treatment options for stress incontinence have also diversified over the years. And in fact, even with pelvic floor therapy, we have more and more pelvic floor therapists available to work with patients to optimize treatment. Most patients with stress urinary incontinence that go through pelvic floor therapy are able to see improvement in their symptoms start to see improvement within a couple of weeks, and certainly by 12 weeks, most patients, and again, about 80% of patients with mild stress urinary incontinence will be dry. So definitely not an option to be dismissed. Urethral bulking and surgical slings are going to be a lot more invasive. Urethral bulking has the benefit of being able to be done under local anesthesia in the office, and surgical sling is obviously going to be a lot more invasive because it has to be done in the operating room. We talked a little bit about lifestyle changes here again when it comes to stress incontinence. Maintaining a normal weight helps, but I often tell my patients, thin patients as well as heavy patients leak. So weight management is not necessarily the hallmark of treating or controlling bladder. It can be a helpful factor, but it's certainly not if you're heavy, it's certainly not a reason to avoid treatment. Pelvic floor exercises, or pelvic floor therapy, as we like to call it, involves strengthening the pelvic floor muscles to optimize the bladder control. The results multiple published reports have shown that working with a pelvic floor therapist with guided therapy usually gives a much better outcome than working alone. But certainly it's possible to do this on your own as well. There are now some self-therapy devices available on the market that patients can use for some self-guidance for pelvic floor therapy. The surgical management involves placing a sling. A sling is a hammock that goes around the urethra and provides that support. The idea here is to get the support tight enough that you don't leak, but certainly not so tight that you can't urinate. So that balance is key. But it's an approach that's been around really for over 50 years, but slings made out of mesh have been around for about 17 years, has probably become the standard of care when it comes to the management of stress urinary incontinence, with success rates upwards of 90%. The bulking agents have been also around for a while, but the material used for bulking has really evolved. And the most recent agent on the market, bulkamide, is really quite amazing. The idea here is to tighten the closing valve. This is bulkamide. It's a gel, and it's injected within the walls of the urethra to tighten that valve. It's a water-based gel. It's very easy to place, and it's durable. And bulking injection used to be a therapy that was considered temporary. So patients had to buy into the idea that they would have to have treatments done multiple times. With bulkamide, once you're dry, it tends to be long-lasting. And so this has really become a very welcome treatment modality that really has changed even our approach to how we offer treatments to patients. And so in my practice, more and more, bulkamide becomes my next step to pelvic floor therapy, even before considering a surgical approach. The advantage of a bulkamide is that there really isn't any downtime to consider. Patients it can be done under local in the office, and there's no restrictions to activities following the procedure, unlike after placing a sling. Now, having said that, slings are very successful. We do offer that to patients as well. And if a patient, for example, is getting a concurrent prolapse repair, maybe the sling might be a better option once you're under anesthesia to just have that done, because the outcomes are slightly superior to the bulking agent, but we're really talking about a very minimal difference, about 80% successful versus 90 to 90% successful for the sling. So I have a little video here.
Bulkamide can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So bulkamide is then injected into the urethra just to restore the normal seal of the closing mechanism of the bladder. And so it's very similar to facial fillers. It remains in the bladder over time. It doesn't cause an adverse reaction to the surrounding tissue. And it's pretty much a permanent fix for stress incontinence in a way that does not restrict activities following the procedure. So it makes it a very, very appealing option for patients with stress incontinence. So it's a safe and effective. 92% of women are cured or improved following treatment with bulkamide. The procedure is relatively simple. It's done in the office for the most part under local anesthesia, and it offers long-lasting relief. What else do you need? So are you ready for symptom relief? If you are, certainly schedule a consultation and start your journey towards continence. We have many options, as you can see, and certainly the future is bright as far as control of the bladder and bowel in this day and age. I will be open to any questions.
Thank you, Dr. Tchetgen. That was so informative. Now we are going to open up the Q&A session for Dr. Tchetgen to answer any questions you may have. So our first question is, what are the recovery restrictions after implant?
Which implant are we talking about?
Axonics.
The Axonics implant. The recovery restrictions are pretty minimal for patients. So there's generally 2 stages to the procedure. So during the trial phase, we restrict from any submersion because so soaking baths and swimming and all would be restricted. That's essentially it. Most patients can return to work. Everything is internalized. The testing device is actually remote, so there's no wires hanging out of you or anything like that. There is a little dressing that needs to be kept dry, but usually I ask my patients to avoid any real strenuous activity because the implants can be moved with extreme shear. So just taking it easy. The whole process generally takes 2 to 3 weeks. And so during that time period, we want to limit any real strenuous activity, but most daily activities are going to be possible.
Great, thank you. I have another one for you. If the implant has to be removed for any reason, would overactive bladder symptoms return?
Yes.
Okay. Is it possible to go swimming with this device implanted?
Yes, once it's all healed, it's absolutely possible to go swimming.
Okay. Here is another one. Can I go off of my overactive bladder medication if I get this implant?
Yeah, so generally, as I try to present during the talk, there's an algorithm or a care pathway. So most patients that get a trial generally have not responded well to medication. And so when we first do a trial of this treatment, it is done off medication. And so the experience would be that the device replaces the medication in a more effective way. Now, having said that, some patients may have this device for a long time and it's been working well for years. And you can still see in some settings some progression of the underlying disorder. So I have not very many, but there are a few patients, almost like with blood pressure control, where you need 2 or 3 therapies to optimize the control. There are a handful of patients that may still need some medications in some setting in addition to the device, but that's really the minority. But for the most part, we progress towards using these devices because the medications have not worked alone.
Okay, thank you. Is it possible for overactive bladder and or urinary retention to contribute to getting UTIs?
Yeah, so let's start with urinary retention. If the bladder doesn't empty well, then that does increase the risk for urinary tract infections. I like to describe it to patients as a toilet that has not been flushed. If you have stagnant urine within any part of your body, then once an infection gets in, it's really hard to get rid of it until you have adequate drainage of the bladder. On the other hand, the overactive bladder actually seems to be worsened by bladder infections. So patients who get a lot of bladder infections are more likely to have an overactive bladder rather than the other way around, because urinary tract infections irritate the bladder. And so if you have an underlying asbestos to your bladder, it may show up more once you get a bladder infection. But there's definitely some interplay between urinary tract infections and either one of these conditions.
Great. Okay, here's another one. Does LASIK interfere with OAB or make OAB worse?
And so I assume you mean LASIK's like the diuretic. If that's the case, it can make OAB worse, primarily because what LASIK does is it makes the kidneys make more urine. So if you have a bladder that's having difficulty handling urine normally, and then now you have a lot more urine coming into the bladder, they'll have more difficulty controlling the bladder. So LASIK doesn't work directly on the bladder. It works on the kidneys, and then you produce more urine, and then that urine now has to be handled. And that's where your bladder's inability to handle the fluid becomes more obvious. Yeah.
Okay, thank you. Here is another one. I have had a bulking agent, sling, medications. Do you recommend the Exonics or Botox? I am scheduled for Exonics right now.
Well, that's a very specific question that's hard to answer without having more information. You know, usually when patients have had that many procedures, I'll do some diagnostic testing to kind of have a better sense of what's going on with the bladder. And it's on the basis of that a decision can be made. It's too specific of a question for me to be able to answer right now.
And then one of our last questions is, what is the best approach to making an appointment?
I'm sure we'll provide that at the end of the presentation, but you can certainly call our offices. I think it's also important to understand, even going in, that a lot of the first-line therapies can be done by any urologist, but certainly as some of the therapies become more advanced, making sure that you are evaluated by more of a specialist can be helpful, because not all general urologists actually will offer some of these treatments. And so, you know, that's where the information helps, because having the information allows you to guide your search towards therapy.
Great. Is this effective for fecal incontinence as it is for bladder?
Yes, indeed it is. Yes. I may not have gone as much into fecal incontinence because I'm more of a bladder specialist, but certainly a lot of my patients that have both fecal and bladder issues will benefit from this device. And many times we work in close, you know, as pelvic health specialists, we work in close proximity with colorectal specialists as well. So if it's not beneficial, then a referral to a colorectal specialist will usually ensue.
Okay. And one of our last questions, I have a sling and an overactive bladder. I am up every 2 to 3 hours at night. Should I consider bulking prescription?
So getting up 3 times or more at night would be considered something we call nocturia, and that's more of an overactive bladder symptom. So a bulking injection is really for stress incontinence. And so I would say upfront, just on the basis of the information that I've received, that no, a bulking injection would probably not be beneficial in this setting of getting up more often at night.
Okay, Dr. Tchetgen, I do not see any more questions coming in. I'm going to turn it over to you for any closing remarks.
All right, well, I'll just conclude by saying that, this is a very exciting time in the management of bladder and bowel control issues. There's a lot more options than have been available in the past. And the bottom line is that most patients don't have to live with this condition, as there's definitely help out there.
Thank you. And that brings us to an end. Thank you, Dr. Tchetgen, for your time. We greatly appreciate you. For the audience, we hope this presentation was beneficial. And yes, if you would like more information to schedule an appointment, please call Dr. Tchetgen's office at 972-394-4500 to schedule an appointment. Thank you and have a great evening.
Thank you. Thank you for moderating.